I have been working in ICMR for a long time, and also coordinating the activities of antimicrobial resistance initiative at ICMR. And I'm grateful to BMJ for making this as one of the areas in which they would like to understand what is happening at ICMR in India, and also what role the doctors can play in combating antimicrobial resistance. So ICMR has been having a flagship program on AMRs for last 10 years, and briefly I will be sharing with you what progress has been made in India and how doctors can actually contribute to towards the containment of this problem in India. So, as you all know, antimicrobials is a very broad basket of drugs, which includes antibiotics, antifungals, antivirals, and they have been the foundation of modern medicine. But one thing which actually is driving antimicrobial resistance is the antimicrobial use itself. Resistance is when a bug develops unresponsiveness to certain microbial agents in certain doses. It's a natural, biological, unstoppable phenomena. Resistance is generally slow to reverse or sometimes completely irreversible, and all antimicrobial agents have the potential to select drug-resistant subpopulation of microorganisms, which then further spread in the hospitals or the community. So there is now a problem of global spread of multi and pan drug-resistant bacteria, which are also known as superbugs, and which are not treatable by the available antimicrobials. So there is a high burden of drug resistance in low middle income countries. Unfortunately, because of the poor surveillance information which is available from these countries, most of the information that we have is from the high income countries. It is projected that it would be associated with 10 million lives lost per year by 2050, and it will come at a very high cost of loss to the productivity. In a recent report which was released by Lancet, there was an estimate of about 4.95 million lives which were lost to bacterial AMR in 2019, and out of which 1.27 million were directly caused by antimicrobial resistance. From India, we know that treating drug-resistant infections in Indian hospitals costs almost 40% more in Indian patients who are infected with drug-resistant infections. And the hospital-acquired infections with drug-resistant pathogens now are actually complicating simple treatments like cesarean sections or other sterile procedures. And these very drug-resistant pathogens, they lurk in our hospitals and as invisible threats and claim invisible lives. The reason I call them invisible is that because of the inadequate surveillance and inadequate understanding of what exactly is the disease burden, no organization is actually capturing these numbers. Now, if we do not address antimicrobial resistance today, it is going to cost us the progress on Sustainable Development Goals, almost 18 targets across 9 Sustainable Development Goals of good health and well-being, quality education, poverty, hunger. They all will be affected if we do not address the challenge today. Now, just briefly stepping back and looking at what has been the journey of antibiotics development and the resistance development, which has followed it like a shadow. As you can see, the penicillin was the first drug which was discovered in 1928, and following that, many drugs have been discovered and put to use. However, only 15 new drugs have been approved since the year 2000, compared to 63 drugs which were put to use between 1980 and 2000. And out of these, only 14 new drugs, only 4 of them present new classes of drugs. Others are mainly analog drugs. So in 2010, when we found that there is colistin resistance in Enterobacteriaceae, the UN declared it AMR as a fundamental threat. Now, antimicrobials are not just used in humans, but they are also used in animals. And the usage both in humans and animals has jumped over years. In humans, it has jumped by 36% in 2000s. 70% of the antibiotics which are actually used in aquaculture are lost into environment. 80% of the antibiotics which are consumed by humans are also excreted in urine and feces. So a lot of antimicrobials are actually present in the environment, which exert suboptimal pressure on these bugs to develop resistance. So all this is contributing to what we see in our communities or in our hospitals. Why should we worry about antibiotic resistance? The reason is that it leads to treatment failures, economic losses. The resistant bacteria in normal flora are replaced by these bugs. Then there are additional infections, adverse reactions, and all this comes at a cost which is to the patient, long-lasting illnesses, prolonged hospital stays. We also see increased mortality in patients having drug-resistant infections, and subsequently leads to resistance selection. Now, what are the causes of antibiotic resistance? Antimicrobial consumption is the single most important risk factor for emergence of resistance. In our country, antimicrobials are available over the counter. Some of the antimicrobials are available only with prescription, but many antimicrobials can be just bought in a chemist shop and consumed. There are rising incomes, and the antibiotics are also cheaper, so we don't mind popping those pills. There is a now online purchase of products which sometimes are done without prescription. Then the patient demands antibiotics from the clinicians because nobody wants to stay away from work, and everyone wants to get well early, without understanding that antibiotics are used to cure certain syndromes and are not they should not be used like paracetamols or multivitamins. Then there are compromised infection practices. This is the most important factor here, which leads to maximum antibiotic use. Antibiotics are used to actually compromise for poor hygiene and sanitation practices. It is done in the hospitals, in ICUs. When you don't want to lose your patient to hospital-acquired infections, multiple antimicrobials are given to patients to cover for poor sanitation and hygiene. And also, there is a very poor risk perception of long-term consequences. There are hardly any studies which prove that if you overuse antimicrobials, what will be long-term consequences. I came across only one study which has brought out some link on the overuse of antibiotics and colon cancer, but more such studies are needed. And we, as a country also, we have very poor patient compliance. The patients don't complete the dosages, they don't take it for adequate number of days. While on one side we have a problem of excess, but then we also know that many patients are not able to access antibiotics. So it is the excess versus excess which is actually feeding the epidemic of antimicrobial resistance in our country. Besides that, we have a poor doctor to patient ratio compared to what the WHO prescribes. There is a lack of diagnostic infrastructure in the country. ID physicians are not available. There is a preference to use broad spectrum over the narrow spectrum antimicrobials. Then there are practitioners of alternate system who prescribe antimicrobials without having any training to prescribe them. Then there is a patient behavior of self-medication and non-compliance. We are also a very large pharmaceutical industry with the unregulated sale, and also a lot of use in livestock, poultry, agriculture, counterfeit drugs, and inappropriate fixed drug combinations which are used, which are available amply in our country. So inappropriate prescriptions is actually one of the key drivers of excess and misuse of antimicrobials in our country. 50% of the antimicrobials are prescribed inappropriately, incorrect indication, choice of antibiotics and duration of treatment is almost faulty in 30 to 50% of the cases. Extensive usage on ICUs and high dependency units, 30 to 60% of usage is unnecessary or incorrect. 90% of antimicrobials are sold without prescription. Upper respiratory tract infections are actually the most common example for which antimicrobials are prescribed, although a lot of it is caused by viruses. Then there is suboptimal doses of antibiotic which are used, which could be due to many economic issues as well, affordability by the patient, etc. And they all lead to genetic alterations which lead to development of multi-drug resistance. Now, just bringing you some evidence from the ground as to what is the evidence that we have that whatever I said is actually being practiced. This is the Indian study from 4 government tertiary care hospitals and 1 private hospitals. They looked at the antimicrobial use in the patients admitted in tertiary care hospitals. And what they found was that the higher generation, 3rd generation cephalosporins was most commonly prescribed drug. And this comes under the watch category of WHO's AWARE classification. More than 1/10 of the patient received 3 or more antimicrobials while they were admitted in the hospital. 7% patients received double cover for gram-negative organisms, for example, colistin or meropenem, piptazo or colistin, or piptazo and levofloxacin. We also see similar findings in the ICMR network, where we are following 30 hospitals. So this is the data from 10 hospitals, and yellow are the drugs which are from the watch category, and the red are the drugs from the reserve category, and the green are the drugs from the excess category of the AWARE classification of WHO. And as you can see, most of it is yellow. So the doctors prescribe a lot from the watch category of the AWARE classification. Then there we also looked at how COVID impacted antibiotic use in India, and this is the study which is published from India. And significant increase in the use of azithromycin, doxycycline, ferropenem, and also hydroxychloroquine during COVID time. This is the study that ICMR did in its own network. We looked at how antibiotics are prescribed in the admitted patients. In the admitted COVID patients, and we found that most drugs were again prescribed from the watch category, and 20% almost from the reserve categories, which includes polymyxin and all higher generation antimicrobials, and BLI inhibitors, meropenem, piperacillin, tazobactam, ceftriaxone, sulbactam, and carbapenems were excessively prescribed. One other very important missing link in our healthcare system is the under-recognition of diagnostics. One of the reasons is that a diagnostic test is more expensive than the antimicrobial. Diagnostics influence actually 60 to 70% of the health decisions, yet our spending on diagnostics is very, very minimal. In COVID patients, we saw that there was a positive correlation between the number of cultures which were collected and the COVID patients who were picked up, who tested positive for secondary infection. So unless we send out cultures, unless we try to find out what kind of an infection it is, we will never get to know. So lab infrastructure, absence of point care diagnostics, they have been some of the key barriers into practicing antimicrobial stewardship guided by appropriate diagnostics, especially in the rural health settings. So this is the case, an example which I would like to share with you. This is regarding how the typhoid drug resistance has evolved in this country. So in 1970, the first chloramphenicol resistance was reported. This was followed by MDR outbreaks, resistance to all the 3 drugs which were being used for treatment, that is chloramphenicol, cotrimoxazole, and ampicillin. This was followed by introduction of ciprofloxacin as a drug of choice. Again, drug failure due to ciprofloxacin were reported, treatment failures were reported, and cephalosporins were introduced. Now we are seeing increasing MICs to cephalosporins, and now azithromycin has become the first line of treatment. But what we are also seeing is that now the typhoid isolates are sensitive to chloramphenicol, ampicillin, and cotramoxazole, because these drugs were not being used for typhoid treatment for a long time. So we don't see this MDR anymore. So this is one classic example how absence of a good test. Badal is not good. There are no good point of care diagnostics. How absence of the diagnostic test for typhoid has actually messed up the treatment of typhoid in the country. And you will, I'm sure in your practice, you are frequently seeing patients with recurrent typhoid. Now, ICMR has a network of 30 hospitals where we capture data and we publish it annually. And what we see is that there is increasing fluoroquinolone and resistance to ciprofloxacin in Salmonella typhi. ESBL rates are as high as 70% in E. coli and Klebsiella pneumoniae. Carbapenem rates are going up by 5 to 10% every year. There is increasing resistance to colistin. Almost 40% of Staph aureus is MRSA. And there is increasing resistance to tigecycline and linezolid. Now, one very important pathogen which has emerged in last few years, that is the Enterococcus, both Enterococcus faecium and faecalis. And faecium is actually more difficult to treat because of vancomycin resistance being 3 times higher. And we also see a lot of resistance to fluconazole in fungal infections. And these results are we publish every year. This is from the non-COVID. In the COVID patients, we found very high resistance to the commonly used antimicrobial, especially the broad spectrum ones in both Klebsiella pneumoniae and Acinetobacter, which were the most commonly isolated pathogens in the COVID patients in our ICMR network hospitals. Something between 40% to 90% in Klebsiella pneumoniae, as well as almost 90% resistance to ceftazidime, ciprofloxacin or levofloxacin. Even meropenem is very high in Acinetobacter baumannii. So the bugs are actually becoming more and more difficult to treat, and this is because of the multiple mechanisms of resistance that these bugs are having. So we published this as well. And now, because we undertake the genotypic characterization of these isolates, we know that many of the new drugs which are being introduced in the market or will be available in some time, they will not be active against the mechanisms of resistance that are prevailing in India. So this should ring a bell that we urgently need to focus our efforts on AMR containment, which includes improving the evidence at all levels of healthcare, improving the diagnostic stewardship so that we have good labs, we have good point of care rapid tests, we improve the infection control, improve sanitation and hygiene in community and hospitals, and improve the antimicrobial stewardship. And most important component here is the education and awareness of doctors as well as community on this issue. There's a national action plan on AMR which has 6 pillars, and new antimicrobial development as well as optimizing the use of existing antimicrobials is one of the key areas for the national action plan. Why new antibiotics should be a national priority? As I already shared data with you, that we are seeing alarmingly high levels of resistance to the existing antimicrobials in our country, and the antibiotics which have been recently discovered or developed in the West, they don't find their way easily into the Indian market. Sometimes there is a lag of 5 to 6 years, and Indian patients then have to endure the treatment with ad hoc cocktails, for many of which there is no scientific basis. Recently there was a severe shortage of antibiotics ceftazidime avibactam, which left seriously ill patients in lurch, and doctors have been craving for new antimicrobials. And the answers, I think, will be coming from India itself, because India is constitutes 18% of the world's population and also has the highest level of antimicrobial resistance. The last resort life-saving therapies are facing challenge of resistance in commonly found bacterial pathogens like Klebsiella pneumoniae, Pseudomonas, and Acinetobacter. Unfortunately, AMR does not draw the required level of meaningful and actionable attention from policymakers as well as pharma. Most of the pharma has exited research several years ago, and our healthcare systems are different, so our needs are also specific, and we would need products which are developed in India, and the products which are developed in high income countries may not address our needs. So we need new products, for which we need evidence, what is happening on the ground, as well as what is most important is that we should be able to put a system in place so that we don't misuse the drugs which are new the same way as we have done in the past, because then again within 5 years, 2 to 5 years, we will also be running out of the new drugs. So antimicrobial stewardship is a global answer for antimicrobial resistance, which means right duration, right antibiotic given to a patient for right duration, right route, right dose, and at the right time, to minimize the harm to the patients and to improve the longevity, as well as cut down the cost on antimicrobials. We did a small survey in 2013 in the Indian hospitals, and we found that most of the hospitals, especially the government hospitals, had no structure or framework for implementing antimicrobial stewardship. There was a structure for infection control in these hospitals, but the AMSP documents were found only in 4 out of 20, and they were also in private hospitals. Government hospitals did not have ID physicians. They would look at antimicrobial resistance data, but no antimicrobial usage data analysis was done, and some hospitals were conducting hospital infection control compliance audit. This was followed by the capacity building initiative, which was started by ICMR, through which we trained almost 300 to 500 staff in 60 medical colleges and hospitals, and we also we undertook workshops as well as created many resource materials like treatment guideline, infection control guidelines, antimicrobial stewardship guidelines. All of these are available on the ICMR website. And this was followed by initiating a small project in the hospitals which are part of ICMR network, where we help them create a structure and process of AMSP. For example, helping them put together an antimicrobial stewardship committee, start the culture of cultures, monitor the antibiotic consumption, initiate prescription audit, or initiate formulary restriction for some of the antimicrobials. We also help them put together a 5-member team, which is trained administrator, physician, microbiologist, clinician, and an infection control nurse for the hospital. And all these projects were led by clinicians, intensivist or ID physicians. And a clinical pharmacist was provided to all these hospitals. And we got a very good response. As you can see that after implementation, which is shown in orange, there was significant improvement on all the indicators which we have captured, whether it is a constitution of AMSP committee, AMR data analysis, hospital antibiotic policy, or introducing formulary restriction. Many hospitals, almost 75% hospitals, introduced one, and they all initiated the practice of prescription audit and review. So 2 hospitals created a permanent post of a clinical pharmacist after the completion of this project, understanding the value that clinical pharmacist brings in prescription. And most hospitals mentioned facing challenges of implementation, like lack of time. Clinicians are very busy, lack of funding for this particular activity being made available by the hospital, lack of trained manpower. Support from peers is sometimes not very easy to come by, because everyone wants his patient to get well, and the modules for data capturing are not available in many hospitals. So we found that this project led to significant improvement in implementation of antimicrobial stewardship activities in tertiary care institutes. The structured training programs and allocating resources are necessary for initiating these activities. And in absence of an ID physician, which most hospitals do not have, leadership can be provided by intensivist or any physician who has a passion for antimicrobial stewardship. So quickly, I will just go through what kind of steps should be taken at multiple levels which can facilitate AMR containment. The first being at the policy level. What should the government be doing? Government has set up a National Medical Commission, and it has made mandatory for all medical colleges to have a AMSP and HIC committees, and they should be functional. It is also now mandatory for all medical colleges to have 24/7 functioning microbiology labs, which are actively involved in patient management. The other recommendations which the government can take up is the accreditation should be mandatory for all government hospitals, and this government has started doing in district hospitals. They are encouraging district hospitals to go for accreditation, so some streamlining will come through that. ID physicians are needed across all hospitals, and also clinical pharmacist posts should be created in all the secondary and the tertiary level hospitals, and this guidance also holds true for the private hospitals. Now, to make AMSP as part of the hospitals, the hospital leadership should be involved. The administrators, they should create AMSP and infection control committees, create guidelines on AMSP, hospital infection control, outbreak management, etc. Then the most important is creating the antibiogram based treatment guidelines, because many a times when the diagnostics are not available, doctors should be able to prescribe empirically if there is a guideline which is based on the hospital antibiogram. Frequent audits, record of healthcare associated infections, system to analyze AMR data trends over a period of time, analyzing antimicrobial usage, having computer assisted programs, and regular education and awareness activities are some other activities that hospitals can initiate, and it goes a long way in strengthening AMSP in the hospital. So what the doctors can do? Doctors can be the champion of AMR in their own hospital, engage with their peers, educate your peers. Most important, what the doctors can do is practice mindfulness, to be present in that moment and not get swayed or driven by the patient pressure or the pressure to prescribe antimicrobials. Hence, they should follow the antibiogram based treatment guidelines. Practice infection control, talk to microbiology department and engage with them, consult pharmacists and pharmacologists on the correct dosages and duration, and most importantly is update yourself. What are the new drugs available? What are their new breakpoints? And most important is that they should be able to counsel their patients whenever the patients press for antimicrobial prescriptions. So these are the various guidance documents which have been published by ICMR on AMR. These can be, these are all available on the ICMR website. So what is the way forward here? We want to continue the surveillance at all levels of healthcare to strengthen evidence building. The misuse of antibiotics must be reduced with an immediate effect, and this is the most urgent need of the hour. Then there is correct usage of available diagnostics should be encouraged, even if they are expensive, because one test for probably detecting a carbapenem resistance costs 5,000 rupees, but having a patient on the drug for 5 days will cost something between 50,000 to 70,000 rupees. And that too, if the patient is resistant to carbapenem, all that money is going down the drain. Education and awareness of the doctors around this issue and the campaigns for community is something that the hospitals or the small nursing homes can organize at their level. At ICMR, we continue to strengthen the research development and research for new drugs and diagnostics. So the take-home message from here should be to prevent infections. At the first stage, diagnose and treat infections when it is not possible to prevent infections. And when treating infections, use antimicrobials wisely, and overall prevent the transmission of drug-resistant pathogens to other patients in the community or the hospital. Thank you.
Thank you, Dr. Kamini, for this very extensive and informative talk that you have delivered. There are certain questions that have been asked, so I will just we'll just go through them.
Yeah.
The first and very most is by a person named Akash from Bangalore, wherein he asks how to tackle multi-drug resistant organisms with regard to specific organs.
So there are ICMR guidelines available for that. In fact, it brings out the management of the drug-resistant the use of antimicrobials actually in specific syndromes. So that is something that can be referred to, and also they should look at the MDR rates, which we publish every year. So having these two documents, I think, should help them decide the therapy for treatment of MDR pathogens in different organs.
Yes. Most of the questions are repetitive and you have covered and touched on most of the topics, ma'am.
Okay.
So, and another question by Dr. Prakash from Pondicherry, who asked, by which group of antibiotics produces more antimicrobial resistance?
Which group of antibiotics? Actually, whatever you use, whenever you use in the suboptimal level, or when you overuse it, it continuously generates resistance. Earlier we were seeing something like 5 to 10 years of gap between emergence of resistance and between the use of the drug and emergence of resistance. Lately, however, we have been seeing something like 4 years or 5 years gap. So when we use higher generation antimicrobial, especially which has many analogs, I think then we see more drug resistance developing very quickly, rather than the narrow spectrum or the lower generation antimicrobials.
Yes, ma'am. True. Another question, though you have touched upon, but there are many people who have asked this: how to reduce MDR resistance in Acinetobacter, especially in the ICUs?
Okay.
How to tackle this organism?
Yeah, so we also face this problem because we work with ICUs a lot in the tertiary care hospitals, and Acinetobacter is the most common pathogen which is isolated in tertiary care hospitals after E. coli and Klebsiella pneumoniae. I mean, there are 4 pathogens which are most important: E. coli, Klebsiella pneumoniae, Acinetobacter, and Pseudomonas. So Pseudomonas has been relatively easy to, among the 2 gram-negative fermenters, Pseudomonas has been easy to manage. It has lower drug resistance levels, around 30% or so, but Acinetobacter is touching almost 90%. And this is not just with the BLI, even something like meropenem, or even the newly introduced drugs, we are seeing very high resistance. Acinetobacter is more of a infection control problem. Whenever you see Acinetobacter, we know that the infection control is not working properly. So that's why it is very important to look at your infection control processes, all the prevention bundles that you are using, the hand hygiene and other methods that you are using to reduce infections. And also, the central lines and the catheters and other ventilator associated. So basically, it is only the evidence and also finding what is the niche for this organism to be there. Where are you getting the infection from? That is actually something that should guide into improving the infection control practices. So Acinetobacter is not something that the patients bring with themselves. Acinetobacter is a bug of the hospital, and it should be treated, and everything must be done to prevent its transmission within the hospital.
Yes. There is a question which is asked by Joseph Paul. How is it possible for the clinicians to get a true information about the use of antibiotics in family practice?
Okay, this is a difficult one. The reason for that is that we don't have community data. So basically what we need is that every patient should undergo a test, but sometimes that is not possible. So in those situations, we should be guided by the community data, and that also sometimes is very difficult to come by, because most of the infections, by the time they reach lab, they have gone through multiple courses of antimicrobials. So I mean, it is very important to get community level data before we can actually decide for the empirical treatment. But in absence of community data, we would have to go as per the requirement of the patient. So as far as possible, we should try to make our prescriptions dependent on diagnostics. I know it's a very challenging task, because The blood culture report takes such a long time to come, and then we don't have many point of care diagnostics. So, and ICMR is working on that. We are trying to bring more point of care diagnostics which can be used to detect UTIs in time, which can be used to detect upper respiratory tract infections. But then till the time that happens, we may have to switch our practices to be more diagnostic based rather than more just based on our feeling or how we want to treat our patient based on how we see the patient.
Yes. There are many questions. I mean, many people have asked the same thing. Do we have any information regarding the current scenario of AMR in children?
Okay, AMR in children, we do have information on neonatal sepsis, but AMR in children, I mean, children mostly have upper respiratory tract infections. And upper respiratory tract infections are mostly caused by viral, and some of them are caused by bacteria. So, for strep pneumoniae or H. influenzae, I think the drugs which were being used earlier are still effective. We don't see much drug resistance there, except when there are gram-negative pathogens which cause pneumonia or which cause infections in children. Then the profile is somewhat similar to what we see in adults, because ultimately they are acquired from the community only, unless the child is in the hospital. So there is not much difference in the profile, but I think in children it is very hard to distinguish between the viral and the bacterial, and that also holds true for the diarrhea. Most of the infections are caused by, most of diarrhea is caused by rotavirus, yet a lot of it is treated with antibiotics when they are not even effective. So that's why I think the understanding as to how can we differentiate between the viral and bacterial infection becomes very important, and the diagnostic for that also becomes of a prime priority for us. Unfortunately, we don't have it right now.
Okay, thank you. There is a question posed by Gayatri, who asks, should we always wait for a culture and sensitivity report for throat and urinary tract infections?
Well, if you have the antibiogram for your community, you can go and prescribe the antibiotic so that the patient feels better. Yet, I think it is always wise to send out the cultures. But I mean, if you don't have the antibiogram, then we will again be, over prescribing antimicrobials if we are prescribing it without a test. I mean, there are indications that will help you distinguish between whether it is a sore throat is viral or the sore throat is bacterial. There are other tests which are available. There are biochemical markers which can be done. So those can be used, but I mean, it's just a non-diagnostic based treatment which has actually led us to this, that we are not even able to treat typhoid with anything other than azithromycin these days.
There's a question by Pratima Sharma. How can we accelerate AMR action through antimicrobial stewardship? How effective is it? So you have already touched upon this.
No, I touched it briefly. I can expand on it because we have some time. So antimicrobial stewardship actually is seen as a concept which was floated by Western countries. They all had ID physicians, they all had clinical pharmacists, they all had infection control nurses. Unfortunately, all the three are missing in our hospitals. Many private hospitals have them, but government hospitals don't have infection control nurses. We don't have pharmacists. We also don't have ID physicians. So in absence of all this, how do we initiate AMSP? And that is what I talked about. I touched in my talk that you can have any clinician who is interested in antimicrobial resistance actually lead this particular activity in your hospitals. You need a multifunctional team for this. You need a microbiologist, you need a administrator support, because unless you have a administrator support, you will not be able to undertake this, because this is a very resource intensive activity, because it not just requires financial resources, it requires the system in the hospital, it also requires trained manpower, and all that will not come forth unless everyone is sensitized. That's why it is very important to create a multidisciplinary team who are able to create a strong case for AMSP and also are able to function as part of Antimicrobial Stewardship Committee. So once you have this committee in place, then you can organize it to meet every 3 months or every 2 months in your hospital, and also assign the responsibilities. One of the most important thing that we found was very effective was the education and awareness activities within the hospital. All the hospitals which are part of ICMR, AMR network, we have set up the structure and process of AMSP there, and they all undertake both within the hospital and the outside the hospital. Doctors are invited to participate in the antimicrobial stewardship workshops or these kind of sensitization meetings. So this we thought was everyone found very helpful. In fact, we have taken a feedback from all the hospitals and what they found most effective when they undertook this project, except for the initial resistance, but then sensitizing other doctors, other peers on the problem of drug resistance. Although there was initial resistance, but overall they all found it very satisfactory, and they also saw that their peers were coming back to them with more questions about antimicrobial prescribing. So this is something which will be a very slow change that will come by, but then you need a lot of patience and perseverance for this to actually happen and take its full shape in hospitals. Most of the hospitals, whenever there is a very sick patient, the AMSP is the first thing that goes out of the window. And you want to give your patient everything because you want to save your patient. But ultimately, even after 2 days, if you are willing to de-escalate, I think that is something that is a very positive change if that can be introduced within your hospital. I'm not able to hear you, Dr. Trupti, you are on mute.
Yes. There is a question by Dr. Ilamati, who says that if a patient is responding to a particular antimicrobial agent well, but the culture and sensitivity report shows high resistance, what do we do in such kind of cases?
Yeah. No, this is something where you have to differentiate between a colonizer and a pathogen. That's what the clinicians do all the time. They say sometimes you can be isolating a carbapenem-resistant pathogen, but then it is a colonizer. It is really not a pathogen. And that is where I think the clinical judgment kicks in. Nowhere it is mentioned that, you know, the report is sacrosanct. The report is, diagnostic lab report is there, but then the ID physician or clinician's judgment, I think that is something that has to go together with the report for the final decision on what should be prescribed to the patient, depending upon how the patient is responding.
There's a question by Ranadir. How to tackle superbugs that include resistance to carbapenems?
Sorry. Can you repeat the question?
Ma'am, how do we tackle superbugs that include resistance to carbapenems?
Okay, so there are other broad spectrum antimicrobials. You can give polymyxin, you can give polymyxin or colistin in combination with the carbapenems. So that's what I was referring to when I said there are no new antimicrobials and the patients are being given the cocktails without even us knowing how effective they are. Carbapenem resistance is going very high in last few years, and there is a drug in the market which is an oral drug, ferropenem, which has cross reaction to carbapenems, and actually ever since that drug has been introduced in the market, the carbapenem rates are increasing every year. So there is some cross reaction there which is not going well for this class of drugs.
Okay. I think we have covered most of them. Another one is, what is the role of a clinical pharmacologist in antimicrobial stewardship? Yes.
So that is the most important link, I think, in terms of do they talk about pharmacologist or pharmacist?
Pharmacologist.
I see a role for a pharmacist in this, in standardizing the dosage and the duration and choosing the right product. So we have provided one clinical pharmacist to all the hospitals, and some of them, as I mentioned, have hired that only for AMR now, realizing how much value they bring to antimicrobial prescriptions. So clinical pharmacist is a very important part of antimicrobial stewardship program. Wherever they are not available, they can be filled in by the pharmacologist, but the pharmacist is the first choice.
Okay. I guess we have touched upon most of the topics. So, and it is the same questions which have been asked. So, thank you first and foremost for this very beautiful talk, and you have given us an insight onto what is the current scenario of antimicrobial resistance. You've also advised on what strategies that need to be taken in order to decrease the antimicrobial resistance, and also you have told us about the national policies that is underway for implementing it. Over to you, Sheetal.
Thank you, Dr. Trupti, and thank you, Dr. Walia, for such a wonderful and interactive session. It was really a pleasure to have you here. Uh, we have got some requests from the attendees that if they could get the recorded version of this session. So I just want to inform everyone that all the sessions are being recorded, and you can find our sessions on Education from India, which is a channel of BMJ India on YouTube. So all these webinars can be viewed on the YouTube channel. We also are happy to announce that the next webinar, the sixth webinar, will be in June. It will be on the primary care in rheumatology. For more updates on the date of the webinar, you can follow us on our social media platforms at BMJ India. Uh, you can see on your screen there is a feedback form. We request all the viewers to please fill in the feedback forms. It's a very short, quick survey. It will help us to improve in our future webinars. And last but not the least, thank you to all our viewers for attending this session. And I am sure you would have most of your questions are answered. And now we formally close this session for today. Thank you once again, Dr. Walia, for
Thank you.
taking the time out, and thank you to our audience. Thank you so much.